Thanks, Dave. All right, well, welcome everyone. Sorry for that brief technical difficulty there. For everyone who has joined us before, welcome back. Thank you for continuing to join these webinars to learn more about how to improve your lifestyle and the lifestyle of your patients. We really appreciate your support. And if it's your first time joining us, then welcome, and it's great to meet you. While we are just getting things started, I'd love to ask you all to just jump into the chat and let us know where you're joining us from and what your profession is. I think one of the really exciting things about SALMA is that we have a whole range of different healthcare professionals, from medical doctors to dietitians, biokineticists, physios. So it's really exciting to see that so many different members that make up the team are interested in lifestyle medicine. So it's great that you can join us. Today, we have Dr. Yakira Mishan, who is our current president. She is going to be teaching us about sleep, which is something that I didn't learn too much about in medical school, so I'm very excited about this webinar. And just before I give a brief introduction to Yakira, I just want to remind everyone that we do have a giveaway running this month. And that is for an air fryer. And if you don't have an air fryer yet, it honestly will change your life as an adult. Just to throw things in without oil, cook it quick and easy. You know, if load shedding is coming on in 10 minutes, you can pop something in and it'll be done by the time load shedding hits. So an air fryer has really changed my life, and I'm very excited that we can give one of you the opportunity to have one. And all you need to do is be a member of SALMA. So if you have signed up, then thank you so much for joining us. And if you haven't, then please let your friends know as well. And then onto our webinar. So Dr. Yakira Mishan graduated cum laude from Wits University, and she completed her lifestyle medicine diploma in 2022 and is our current president. She is passionate about lifestyle medicine and the opportunity to help patients and communities improve their health and well-being. She's currently working as a GP with a focus on lifestyle medicine. So if you have any questions about that, or you're interested in having a consultation, you're welcome to pop her a message. And after feeling the change that good sleep hygiene made in her life, she then became passionate about sleep and sleep science and promoting the power of sleep for her patients and her fellow healthcare workers. So very excited to have you speaking to us today, Yakira, and over to you.
Thank you so much, Roxy. I'm very excited to be here and to be able to share with all of you. I'm very passionate about sleep and the effect it has on all of us. And I think before we start, just take a moment to think of what happens when we sleep deprived and what happens when we post-call. I compare myself to like a thin sheet of glass, because I know that the smallest of things is going to make me crack. And I think that speaks to a lot of us. So if we just come off that back burner of really understanding why we're here and why we care, then I'm so excited to be able to speak with all of you. So sorry, just one thing. Roxy, are you able to activate it so I can share my screen and the presentation with everyone? Sorry, guys. There we go. Okay. Can everyone see my screen? Thumbs up.
Yeah.
Okay, excellent. Yep. So I've named today's webinar Sleep as the Magic Pill. And the reason I've done that is because, as we're about to realize, if there really was one pill that made us live longer, live better, live healthier, just be better people, it would be sleep. And as we spend a third of our life doing it, we've unfortunately as a society come to completely devalue it. And that's really sad. So today we're going to actually counteract that for ourselves and with that for our patients. So, oh, sorry. What is sleep? Now, sleep is definitely not a period of inactivity. It is not a period where we're just resting, as if we're lying on the beach and nothing's happening. Instead, it's a very active, very regulated, and very metabolically distinct state. And ultimately, it is essential for our health and well-being. And the reason we care, the reason we are all here, is America estimates that 50 to 70 million people in America itself have a chronic sleep disorder. South African data is a little bit old. The latest one I could find was published in 2018, so pre-COVID, and we do know the world's changed. So it would be nice if we had a comparison. But what we see is that in rural communities in South Africa, the prevalence of insomnia is 7%, and it goes up to 21% among patients who are 65 years and older. And that's due to a number of factors, one being age, and the fact that with aging, our sleep does change. But 21% of people, which means a lot of us and a lot of our patients are going to be struggling with sleep. So here's the fun part. What does it take to fall asleep? What is falling asleep? I did tell you it's not just lying there. I did say it's this active state. So if we look at sleep and awake, so picture A over here is awake and B is sleeping. What we'll see is it's a very flip-flop activity. So you're awake or you're asleep. It isn't really an in-between stage, okay? Now, when we're awake, we have a whole bunch of neurotransmitters and systems in our brain that are keeping us awake using quite excitatory neurotransmitters, things like acetylcholine and dopamine and serotonin. And they act to really keep us awake and act as our ascending arousal system. So then, how do we turn that off? How do we go to sleep? Well, we have this area called our ventrolateral preoptic nucleus, our VLPO. And that VLPO is very sensitive to adenosine, which, as we're going to learn, is important for sleep pressure. So as adenosine builds up in our brain, the VLPO starts to signal and realize that and get sleepy and starts to inhibit some of this excitatory activity. We also have an area in our brain, it's not labeled on this particular picture, but our suprachiasmatic nucleus that speaks to our pineal gland to release melatonin. And once the melatonin is released, it too is going to act in this inhibitory way and help us fall asleep. And that is that transition. And when they're looking at what happens in a functional MRI, the brain is pumping while we're sleeping. Our hypothalamus controls sleep and wake, so it's active. Our hippocampus is for memory formation, pumping and active. And as we're going to learn, our memories are formed basically and consolidated while we're sleeping. The amygdala, which a lot of people will know as the seat of fear and emotions, extremely active while we're sleeping, especially while we're dreaming. The thalamus, which is the relay center, is inhibiting sensory inputs from reaching the brain. And that is why a small noise doesn't wake most people up. You need much more sensory stimulus because the thalamus is actually blocking those sensory signals from reaching the brain. The reticular formations, all of this, all the writing here, keeping us awake. And then we finally have in our brainstem, in our pons over here, something called your paramedian pontine reticular formation, and that's responsible for our movements, and it becomes very active during REM sleep, which is our dream state, and is responsible for our eyes are moving. So in short, falling asleep is this complex interplay of numerous parts of our brain that have to all be doing what they're supposed to be doing to put us to sleep, but once they do, we fall asleep, and sleep-wake is almost this flip-flop switch. Okay, so it's this we have this flip-flop switch. What kind of puts us to sleep? What keeps us awake? So we have two pressures in the body. So if we look at this blue line, the navy one here, this is our sleep pressure, sometimes called homeostatic pressure. And what that is it's basically that the longer we are awake, the more we have adenosine as a byproduct of ATP usage in the brain building up. And if we remember a little while ago, we said that adenosine activates your VLPO and makes us sleepy and puts us to sleep. caffeine, for example, binds to adenosine receptors and blocks them. And that is why caffeine makes you awake and interrupts your sleep. Okay. So as we can see, from 7 a.m. all the way, we're active, we're doing stuff, our brains are working, our bodies are working, and that adenosine builds up and up and up. And the second we fall asleep, it decreases quite quickly. So we say that this one basically helps us fall asleep, but it doesn't help us maintain the sleep because that sleep pressure falls really, really fast. And that's something to keep in mind when we're looking at napping. Then we look at our circadian rhythm. So our circadian rhythm refers to the body's ability to move with time. And naturally, our circadian rhythm is 24.2 hours, meaning it's slightly longer than a day. And it is why we rely on sunlight to reset our circadian rhythm so that we don't fall out of sync with the time of day. Now, the circadian rhythm is set peripherally and centrally. Peripherally, in all our cells, we have enzymes and little proteins that keep track of time to some extent. But the ones that are really important with sleep and general functioning are central circadian rhythms, our central oscillators, which actually lie through the visual system. So in the eye, we have cells that see color, we have cells that see black and white. But in the retina, there's also cells that were discovered in roughly 2005, so relatively new, and they called the intrinsic receptor photoganglion cells, IRPGs. And they are very sensitive to blue light, specifically UV lights. And that is why blue light, everyone will tell you, keeps you awake at night. Because what happens, that blue light enters our eyes, that signal goes to our suprachiasmatic nucleus, that then tells our pineal gland, no, it's day, less melatonin, less melatonin. And we need that melatonin build up, and that comes when there's darkness and this inhibition falls away. And that would be roughly here in the cycle. Our circadian rhythm now saying, okay, we're going to go to sleep and then we will wake up again. And this rhythm is not just important for sleep, it is important for hormones, hunger cues, and numerous other bodily systems. So that kind of counteracts the sleep pressure. And the combination of the two, so that building up of sleep pressure combined with that increase in melatonin allows us to fall asleep. And what helps us wake up is that inhibition of melatonin from sunlight and the decrease in sleep pressure. And the combination of the two is basically what puts us to sleep and keeps us awake. So now we get to the stages of sleep. And effectively, there are two big classes of the stages of sleep. We have non-REM and REM sleep. So non-REM sleep is further divided into 3 categories, but makes up about 75% of the time we're asleep, with REM sleep being the other 25%. On top of that, we cycle through these 4 stages about 4 to 5 times each night. And for people, it's a bit different, but on average, the cycle will last 90 to 110 minutes, and then you repeat it. On top of that, these cycles do not look the same throughout the night. So in the beginning of the night, we get much more of this non-REM sleep and less REM sleep. And as the night progresses, that reverses, and we're going to get a lot more REM sleep. Okay, so what happens as we progress? What do each of these cycles mean for our body? So stage 1, a non-REM sleep, is short. It's like 5 to 10 minutes, very light sleep. Often when people wake up in that time, it's almost like, was I really asleep? And this though is a period where our body starts to slow down. We still get a slow decrease in heart rate and blood pressure. Then we hit stage 2, a deeper sleep. And at this point, we really get a lot of a parasympathetic drive. So our blood pressure drops, our heart rate drops, and our temperature drops as well. And we spend about 50% of our time sleeping in this stage 2. What's very cool on EEG, we start to get something called sleep spindles, and that is memory consolidation. So already from the very beginning of our sleep, we start to see the impact and that our brain is busy. It's processing everything that happened that day and integrating it into previous experiences. We then actually move into stage 3. In this stage, we're in a very deep sleep, your blood pressure drops, your your deepest sleep occurs. And this is important because it's what allows us to feel refreshed in the morning. It's what makes us feel like our body battery was actually recharged. And the final stage is REM sleep. So in REM sleep, our bodies are paralyzed except for the eyes that are moving. That's why REM stands for rapid eye movement. And it's the part of our sleep where we are dreaming. And this is important because dreams are thought to be part of our brain problem solving, being creative, memory formation, and forgetting. We need to forget sometimes in order to remember, as well as emotional processing. And all of that is going to be happening in our REM sleep. Okay, so now we've looked at what happens to fall asleep, what allows us to regulate that sleep and awake, and how the day impacts it. We've looked at the stages of sleep. So that's the hardcore science. That's the physiology back to second year kind of stuff. So now we really start to look at why. Why do we care, right? So I asked you in the very beginning to really think of what happens when you are sleep deprived. If you have children, from that, if you're a medical worker, from the system making you stay up for 36 hours. And I think it's easy to really anecdotally understand that we are not our best self. But if we just think about what we spoke about, we said that while we're sleeping, we're consolidating memory. Our amygdalas are active for fear extinguishing and emotional regulating. Our REM sleep is there for problem solving and creativity. And the whole brain is resting in order to improve our impulsivity and risk-taking behavior. We also have that upregulation of our parasympathetic nervous system, especially in that stage 3, by then is at the highest, and our blood pressure drops and our heart rate drops. And that's important for our cardiovascular health. The hormonal control from sleep we're going to look at a little bit further, but that's important for appetite. Stage 3 sleep is imperative for growth hormone release, and that's important for muscle repair, cellular repair, and then finally our immune system functioning. And that works actually in a really nice bi-directional manner. So for example, when we're sick, we do know we feel really fatigued and want to sleep. And that's actually because when we're sick, we release cytokines, things like interleukin-1, tumor necrosis factor alpha, prostaglandin, and these actually drive our body to sleep more and stimulate specifically your non-REM sleep. So it's quite a nice interplay of the fact that our immune system needs sleep and it knows that. So when we're sick, we want to sleep more by virtue of our body's fight response against it. Okay, so obviously we can deduce what happens when we're not sleeping, but I think these numbers are important, and they're very important in the world we live in, because we kind of work and live in a society that tells you that sleep is for the weak. I'll sleep when I'm dead. Everyone you meet will be like, oh, I'm exhausted, I pulled an all-nighter. And these are almost heralded as achievements and accomplishments. And without actually having those facts and figures and numbers behind us, it's very easy to almost get swept up in that and to really feel that that's what we should be doing. We shouldn't be sleeping. But, so this is from Johns Hopkins, so it's in America, but I think that the numbers are pretty similar across most populations. And that's, if you just look at 6,000 fatal car crashes. So what happens? How does that happen? Because chronic sleep deprivation is basically equivalent to being drunk. And you have delayed reflexes, and you get these things called micro sleeps, where you basically nod off. But they're so short, maybe 2-3 seconds. So it's not like when you nod off at the wheel and wake up and you're aware of it. It's so quick, you don't even process it. But that's all it takes when you're operating heavy machinery at a height or in a car to have something really serious go wrong. The scariest part, and I think new parents often attest to this, that chronic sleep deprivation, you stop feeling. So people stop realizing and they almost adapt that they're so exhausted, but their impairment does not improve, and they're functioning at 40% of their capacity and ability without realizing how tired they are, which is very dangerous. Okay, then if we look at our immune system, so this is a very busy picture, but what we really want to look at is the effects of the inflammatory cytokines on things like our blood-brain barrier. We want to look at the fact that it affects our gut microbiome, gut, metabolic waste clearance, and this system here where our immune system becomes dysregulated from sleep deprivation, which means that we are more prone to illness. Vaccines, so trials have shown that post-vaccination, patients who are sleep deprived do not mount a sufficient immune response. Cancer risk goes up, and really highly actually. So there's a decrease in our natural killer cell function, which is important for our anti-tumor responses. So our body's own way of clearing out those cancer cells falls away. And you can see here, there is even up to 36% increased risk of some of the most common cancers, like colon cancer, just from being sleep deprived. Then finally, another important factor is obviously the role it has in obesity and cardiovascular disease. So basically, prospective epidemiological studies have shown that sleep deprivation, less than 7 hours, but very often even less than 5 hours, increases fatal and non-fatal cardiovascular outcomes. There's a 48% higher risk of coronary heart disease. That's basically 50%. That's huge. And a 15% higher risk of stroke. How does that happen is in twofold. So when we are sleep deprived, we start to have this endothelial dysfunction, because during sleep, our endothelium repair and heal. So endothelial dysfunction develops into atherosclerosis. We also have an increased level of sympathetic drive to parasympathetic drive in our 24-hour cycle because we're not sleeping enough. So we're not getting that therapeutic drop in blood pressure and heart rate from sleep, which means we have increased risk of things like heart attacks and strokes and hypertension. We also then spoke about our chronic immune dysfunction, cardiovascular disease, type 2 diabetes, all of those increase. So those are big risks to take. Chronic sleep deprivation, 50% increased risk of cardiovascular disease. Really high rate if you think about it. But that risk extends further, and is why we see diabetes more commonly in patients who are chronically sleep deprived, as well as obesity. And some of that has to do with an increase in eating. So we mentioned earlier that while we're sleeping, we have regulation of ghrelin and leptin. Ghrelin is the hormone that makes us hungry, while leptin makes us full. So this imbalance makes us eat more. On top of that, studies have shown that people are sleep deprived the next day. So it's literally a 1-for-1. They're going to eat more, up to 500 to 600 calories more, which is basically an entire meal. And on top of that, they're going to choose your high calorie foods. They're not going to be eating 500 calories worth of apples. They're eating 500 calories worth of donuts. And that also comes out a little bit further when we think about things like hedonic responses, and the fact that we get less increased hedonic signaling from food, and all of that drives eating more. More than that, we have decreased sleep, and that puts us at risk of eating more because we're awake for more time. And typically if people are awake for more time, they're eating later in the day and then going to sleep without having an opportunity to really burn off those calories. And finally, I think we all know this, exercise can be a challenge at the best of times. So what's the best excuse? I'm tired. And that's definitely a 1-for-1 link, that we're tired and we don't exercise. So taking a step back, that day, that post-call day when you're just not feeling great, a lot of that's in that emotional level. We know we're emotionally less stable, and people are chronically sleep deprived they're more prone to develop depression and anxiety. But we also know that, oh gosh, what's happening on our insides? What's this doing to our immune system, our heart, our metabolism? And we're starting to get a pretty big picture that it's not a pretty picture, and it's really dangerous for our health. Okay, so I've chosen to just talk on 2 of the more common sleep disturbances affecting probably us and our patients. There's so many out there, but I think, obviously certain and more complex ones are for sleep specialists, but this is definitely at a GP level, definitely in a clinic, and really just for all of us to be aware of. So the first one is insomnia. And just to put in perspective, insomnia affects about 10% of the population. It's a point prevalence from America, but the same was found in other countries as well. And basically, what is insomnia? Because people also, to be honest, misuse that term. But basically, it's a problem sleeping. And that can be difficulty, falling asleep, staying asleep, or waking up too early and not being able to fall back asleep, so early awakening, for at least 3 nights per week, okay? And the key function is just like when we look at the DSM-5 and psych diseases, it has to impair functioning. Same here. This results in daytime symptoms. So fatigue, poor concentration, irritability, and this is a big one. And if you think about children, behavioral problems, chronic pain, etc. So people can't sleep and it makes them miserable and moody and unable to function in the morning. And they're falling asleep doing things like driving or watching TV or talking to people at the table. And the question is here, it says for more than 3 months. So you do get different time periods. So transient insomnia is less than 1 month. Short-term insomnia is 1 to 6 months. Chronic insomnia is more than 6 months. So here's the big one. Who gets insomnia? Because quite frankly, I mean, it's a bit scary, right? And anyone who suffers from chronic insomnia will know it's a really terrible condition, because people are tired and then they try and sleep and they can't. And then they're frustrated and then this repeats. And the daytime functioning is excessive. They're struggling to do their work. They're struggling with interpersonal connections. They're chronically exhausted. So who gets insomnia? So we have predisposing, provocation, and perpetuating factors, because ultimately, unfortunately, anyone could get insomnia. So predisposition is that obviously some people are just more at risk, and we do see it running in families, and there does seem to potentially be a genetic component. Age, so as we said earlier, 65 up, there was a 21% prevalence versus 7% overall in the population. So age is a factor. Sex, females are more prone to anxiety. And then you get secondary insomnia. So that means that this insomnia is secondary to something else. So substance use and abuse, for example, and chronic other conditions. So your anxiety, your depression, and then obviously physical conditions, pain, fibromyalgias, migraines, rheumatological conditions. All of those obviously stop people from sleeping. And when they do sleep, it's usually not very well. So those are our predisposing factors. We then start to head into our precipitating factors. And these are things that trigger a short term of insomnia, that's like less than 1 month transient insomnia. And we definitely want to act quickly, because that's obviously where it's easiest to reverse the insomnia complications. But when we look at that, that can be things like poor sleep hygiene, which we'll discuss in a little bit, traveling, shift work, and typically it's actually stress. So people are losing a job, or they have just had a child, or they're having family problems, and all of those mount to not being able to sleep and waking up in the middle of the night. And from that, what often happens is what we call our perpetuating behaviors. People can't sleep well, they're tired, they start drinking coffee late in the day, they can't sleep well, and that's a cycle. Or they're tired, they can't sleep, then in the middle of the day they have this really long nap, then they can't sleep at night, and that's another cycle. And I think one of the biggest one is to realize in any patient with chronic insomnia how much anxiety they're bringing to the consultation, and how much they almost create these excessive rituals around sleep and become very very superstitious, that if this happens they won't be able to sleep, if this happens they'll wake up. And at this point, it's psychologically a very, very terrible state, because they get into bed ready to watch the clock, ready to not sleep, already fearing what's going to happen the next day. And that's your biggest perpetuation. So brief, because we're going to go into it in a few more slides. Our treatment needs to center around sleep hygiene, stimulus control, sleep restriction, in some instances, medications. But definitely by the time you're seeing patients with that really chronic insomnia and anxiety, it's advisable to send them to a psychologist trained in cognitive behavioral therapy for insomnia specifically. They need to break those very unhealthy cycles to actually get back into a normal sleep pattern. Okay, so this is behaviorally induced insufficient sleep syndrome. And personally, I only learned about this recently, like in the last 2 years. but it definitely was me for a really, really long time. And I think realistically, especially as healthcare workers, it's all of us. So what is BISSS, or insufficient sleep syndrome? And at worst, it's a choice. It is that we are having hypersomnolence, meaning excessive sleepiness, as a direct result of allowing ourselves to only have a shorter sleep duration. So we either restricting our sleep or keeping ourselves awake for a lot longer. And realistically, this has pretty much become a norm in our society, with up to 30% of American adults reporting sleeping an average of 6 hours or less. And what's even worse, 70% of high school students getting less than 7 to 8 hours. That's really concerning. They need to be growing, they need to be developing, they're already prone to things like high risk behaviors, and they're meant to be learning. Okay. So if we look here, this was from 2013, but it just starts to really highlight, firstly, that there is a cultural element. We see it much more in our English-speaking countries and Japan, countries that are very favoring high outputs, high economic stresses, and less of a socialist system, so more pressure on people to earn, to, let's say, pay for things like healthcare. And ultimately, as healthcare workers, we are exceptionally prone to this because of the work we do and the systems we work in. But so are our patients, especially our younger patients, trying to run families, build careers, maybe study. Very often people will tell you they're tired because they only slept so little. So what can we do about that? And ultimately, this is where we need to whip out that coach approach. It's where we need to use our motivational interviewing. It's where we need to really counsel our patients and help them understand. So this is a great picture. And I think what's really nice about this is if we just look at everything on this page, okay, so there's almost a direct consequence to almost any patient you'd be seeing. So let's take a young student. Medical students, a great example. They proudly tell you they're exhausted, they're getting 5 hours of sleep a night, and they're coming to you because they feel almost depressed and they just don't know why. By using something like this, we can show them that sleep, they're not getting enough sleep, is possibly one of the biggest factors leading to their depression. It's a very strong link. And then on top of that, we can directly show them that their behavior is not helping them and that this is just not a beneficial activity. So they're trying to stay up all night to study, but what happens when we sleep restricted? Oh, look, our learning and academic performance go way down. So this is a picture I utilize a lot in my own head, and it's something I think we all need to really realize, because we all can say, but I need to stay up because I need to study, but what about this? Or I should stay up to go to that party and stay out late. But in the long term, our social functioning, our judgments and our interpersonal relationships go down, our mood is impaired. So we start to really understand that if we really think about what we're trying to achieve with the activity we're staying up all night for, that all-nighter stops being worth it. And this is what we owe our patients and ourselves. We owe them this change and reframing, so that what's really important to us is central, and realizing that sometimes getting sleep so that we can learn better in the morning makes way more sense than falling asleep in our notes at night and absorbing none of it. Okay, right. So I hope now we are all convinced that sleep is like amazing and it's this magic cure, and we're going to just live this brilliant life and sleep great. How are we going to do that? So to feel rested and to get good sleep, we worry about quality and quantity. So quantity is hours, how long you slept for, but the quality has to do with those early slides where we spoke about stages and REM versus non-REM and all of those, and putting it into perspective to make sure that our sleep architecture is very good. So sleep hygiene is for everybody, regardless of if they think they're a good sleeper or not. It basically refers to having those great healthy habits that allow us to sleep well. And some of them are really simple, but the biggest message is getting a good night's sleep does not start with the wind down routine an hour before bed. It starts from the moment you wake up. So one of the biggest things is getting sunlight, especially early in the morning. Why? Because that light and that nice blue UV rays, blue spectrum UV rays, make our intrinsic photoreceptor ganglions awake, inhibit that melatonin release, and reset that clock that is longer than 24 hours and start to reestablish it at 24 hours to help us fall asleep and wake up at good times. And that's also why we really encourage people to have a regular bedtime and a waking time. Our bodies need to get into a routine, and it's very hard for them if things are all over the place. Then small things. So naps. Naps are good. Some people love naps, but we want to keep them short. We want to keep them at less than 20 minutes. 20 minutes to half an hour, less than half an hour, because we want to not get into too long a sleep cycle, because then you wake up very groggy, confused, disorientated, and almost more tired than when you went to sleep. We also want to say that there's a time limit. So let's say 2 p.m. in the afternoon, usually the quoted one, because if we sleep after that, that sleep pressure, if we think of that second slide, falls away. And then when we try to go to bed, there's no sleep pressure putting us to sleep. That adenosine is gone. And the same actually refers to the caffeine, because that caffeine blocks those adenosine receptors. And then there's nothing making you tired and want to go to sleep. Now, many people will tell you that, but you know, doc, I can have my cup of coffee and go straight to sleep. So there are a few problems with that statement. One, they're clearly so sleep deprived that they've now built up a complete tolerance to this adenosine receptor blockade that is like overcoming it. And really, it's just signs and cycles of what we were talking about before, where people get into these really bad cycles of not sleeping and then drinking coffee to stay awake. The other side of it is there are studies that show that even if people fall asleep, their sleep architecture is disrupted. And sleep architecture disruption means they're not getting that adequate non-REM sleep to REM sleep ratios, and they're not waking up feeling refreshed, and then they need more coffee. So these are the patients that are hard to explain this to, but it is important to counteract it and say and explain it to them, because all they're really doing is keeping Starbucks in business, and what they're really not doing is getting a good night's sleep, even if they think they are, because they are confusing quantity and quality and thinking that all they need is the quantity without any focus on the quality. Okay, and that also brings us to alcohol use. So alcohol works like our benzodiazepines. It's a central nervous system depressant. So it puts you to sleep. But as anyone here knows, when you go out at night, after that dizziness wears off, you fall asleep. And what happens? You wake up the next morning feeling terrible and you are tired, even if you're not hungover. And that is because of, again, that disruption in sleep architecture. So we advocate that if you're going to have your nightcap, do it infrequently, because regular alcohol use is just not great for your health and increases your cancer risk and 100 other issues. But keep it to 3 hours before bed to let it clear your system and not disrupt your sleep. Exercise is also a great one. Exercise and regular exercise routines help us sleep better. The time of day we exercise, some research has shown that the afternoon, your 4:35, that kind of time zone, is the most beneficial for sleep, because it allows you to activate your SNS, increase your core temperature. And what happens then is your body slowly cools down a few hours later in time for you to fall asleep. And core temperature reduction is an important factor in falling asleep. That being said, if you're a morning gym and it works for you, that's excellent, and any regular routine will help you sleep. The only thing we say is don't get exercise just before bed, especially your hits, your weights, anything that increases your heart rate. It will amp you up. You have that sympathetic drive afterwards, and you ain't falling asleep so well afterwards. Then I think without saying, we I think are all pretty familiar with the idea of a comfortable temperature. We want it to be a bit cooler, comfortable bedding, make the room dark, make the room quiet. And finally, just one of the last things I think, which is quite a nice one, is your bedtime snacks. So carbohydrates make us awake. So for example, this is me. I wake up and the first thing I want is breakfast. I am perpetually starving. You can wake me up at 4 a.m. for a hike and I'll be like, okay, cool, where's my breakfast first? Now, I thought I was crazy, but the truth is that's actually what's supposed to happen. As you wake up, your cortisol spikes and it drives hunger. And as a result of that, carbohydrates help our body wake up. And therefore, if people need a bedtime snack, maybe they're diabetic and they're worried about their sugars, maybe they're just really hungry, it's important to focus on a very small meal, not too many carbohydrates, and to keep it quite small so that we're not having all that added stress and pressure on our body and energy keeping us awake. So these are the habits that will work for everybody, and they help most patients, especially with transient insomniacs. Where we might need to up the antics a bit, and we'll about some slightly bigger guns. So when people haven't been sleeping well for a while and they've started to develop all that anxiety, we know that we need to encourage stimulus control, which is basically almost like operant conditioning back from psychology first year. And that's basically reassociating the bed with sleep. Okay, so we advocate to say, only go to bed when you're sleepy. If you cannot sleep, get out of the bed. So even things like reading in bed is not allowed. The bedroom is quite literally for sleep and sex, or the bed at least, and nothing else, okay? Avoiding naps, and we encourage them to wake up at the same time every day. And the reason is to really try and set that circadian rhythm, because if they wake up, they can't sleep, they fall asleep late at 2 a.m., they let themselves sleep in and they wake up at 10 a.m., they're not going to be able to fall asleep at a good time that night, and that's going to start becoming their rhythm. And then it's difficult to function in a society that wants them at work at 8 a.m. So we say, even if you're going to be tired, you wake up at the same time every day. And finally, the last point is sleep restriction. This is quite extreme. It's useful in patients who've kind of tried everything and are a bit desperate, because it requires them to be very motivated. You basically get them to sleep and log how long they're actually sleeping for. And then let's say they're only getting 6 hours of sleep. They're only allowed to be in bed for 6 hours. Once they're hitting 85% roughly sleep efficiency, meaning they're sleeping roughly 85% of the time they're in the bed, you slowly increase that at 15 minutes, half an hour intervals, and slowly build up with them this ability to sleep longer. It takes a while, requires a lot of input from the patient. And obviously it's really hard because you're literally limiting them back to how much they were actually getting. And finally, we move on to the last section. So we've tried everything. We have our blue filter goggles, we're getting our sunlight, we're not eating carbohydrates at night, we've given up the coffee, and coffee roughly has a half-life of 7.5 hours to 9 hours. So last cup of coffee was, let's say, at 2, so that we can go to bed at 9, 10. What about sleeping pills? Now, I think that the biggest message around sleeping pills is no. Keeping it simple, that's the one take home, is rather not. And I say this because unfortunately, I think our training around sleep is very poor in medical school. And throughout our training, then as interns and ComServes, many GPs, so what we see around is this prescription of sleeping pills to every patient who can't sleep. And that is not the answer. So we're going to go through all the different kinds quickly, but just so you know, the American Academy of Sleep Medicine does have really nice guidelines of what to use when. But on the whole, the recommendation is to really only use sleeping aids short term, roughly maybe for 8 weeks at most, and to rather leave it up to fully trained sleep physicians if the person needs longer. So quickly at our prescription meds. So the first one are benzodiazepines. Okay, they're the go-to often. I think falling a little bit out of favor for the Z drugs, but effectively they're GABA alpha-1 receptor blockers, and they activate the GABA receptor agonist, they activate the GABA receptor and open chloride channels. And as we go back to the very first slide, GABA was inhibitory and helps us to fall asleep, activates that VLPO region. The biggest issue in terms of sleep for benzos is they're sedatory, right? We give it to psychotic patients when they need sedation. People take Volmicum for sedation before an operation. So what are they doing? They're making people sedated. That's not the same as sleep. They will fall asleep, but their sleep architecture is disrupted, and they will wake up feeling tired. Some other big risk factors are obviously the respiratory depression, especially if taken in overdose or with other drugs, the high risk of dependence and addiction. And just to remember, if you're seeing a patient and Unfortunately, this isn't uncommon, right? That they've now become addicted to their sleeping pills and they need more and they need more and they're really addicted to them. Just remember, benzos like alcohol, withdrawal will kill. So you can't ever just tell them to stop. They need full programs and weaning of those benzodiazepines, which is just something else to keep in mind, that to create a person who's addicted to a substance that they stop taking it quickly will kill them. That's how serious this can be when we dish out pills as the answer to people telling you they can't sleep. And then very briefly, to keep in mind that who gets it the most are the elderly, right? They're the ones who are not sleeping well. And the effects of benzos are much longer lasting, that like hangover and sedation, as well as their risk of, let's say, waking up in the middle of the night and they're sedated and they fall and like break their hip. And the reason for that is because they have slower metabolism because they're metabolized in the liver. Okay, then Z drugs are newer drugs, things like zolpidem, and they have a significantly better profile. So they work, and the mechanism of action is actually very similar to benzodiazepines, but they have been shown to reduce sleep latency, i.e. time to fall asleep. They improve sleep quality, but we don't know if they actually increase how long people sleep for. And the biggest thing with them is they have a shorter half-life. So the risks of the morning after feeling all tired and sleepy is a bit less, and okay to use in the short term for certain patients who really need them. Again, 2 weeks to 8 weeks. We don't want them longer. There is still a risk of dependence. Antidepressants. So when we look at our tricyclics, they have anticholinergic and antihistamine properties, and that makes people sleepy. And that's actually how things like your tryptoline work, commonly used, especially in patients with pain and sleeping problems, to really just keep in mind again that anticholinergic side effect risk profile, the fact that they're lethal in overdose, and the effect of making people reliant on pills to sleep and feeling that they cannot sleep without them, and psychologically how that perpetuates insomnia. Antihistamines, your first generation H1 receptors, so your diphenhydramine or Allergex commonly. So we know that Allergex makes people sleepy. Again, if used short term, patient has pruritus, get rid of the itch, help them sleep, it's a win-win. And I think that's the thing, that they can be really beneficial in the short term. After 10 days, the research shows people build up tolerance. So they're not going to really find that they fall asleep as well with them. Again, we don't want to encourage those anticholinergic side effects, especially in the elderly, urinary retention, confusion, and things like that. Finally, there's a new class of drugs called melatonin receptor agonists, like Rameltia, and they have been shown to be pretty promising in helping people fall asleep, and is currently being investigated for that. Then a quick word on supplements, because these are common. So melatonin supplements are beneficial for patients with jet lag, shift workers, or circadian rhythm disorders. Basically, 2 to 4 milligrams helps a person an hour before bed. It triggers the natural melatonin, it stimulates the melatonin receptors, and they do feel sleepy, and they will fall asleep. They also come in long-acting forms that will help them stay asleep, which is great. Just remembering that if patients don't get roughly 7 hours of sleep, they will wake up feeling sleepy and hungover still, because that melatonin is in their system. The current research has not come to a conclusion over use in chronic insomniacs, nor do we really know the long-term effects, but definitely jet lag, circadian rhythm, and shift workers. Valerian root, used in many traditional cultures, and has actually been shown in some effect in a randomized placebo-controlled trials that it does improve sleep quality, decreases sleep latency, and doesn't result in that hangover effect. So it comes in multiple doses, but we basically advocate 300 milligrams to 600 milligrams of a 1% concentration before bed, and to just encourage patients to take it for a while, so 2 to 4 weeks, because only then will they start to really see the benefit of it. Just like any other, it is a CNS depressant, so to keep in mind and make sure patients aren't taking it with other CNS depressants, and in any patient check drug interactions. But it's not a bad option, especially in patients who really are struggling to sleep. It does affect the sleep quality a lot less and is less addictive than at least from the few randomized controlled trials that have been done. CBD, currently under investigation. Hard to investigate because of all the various forms and almost the lack of standardization. Currently has been shown that it can decrease anxiety. So I think it's a very watch this space over if it will help people sleep. And finally, for chamomile tea, it has been approved by the FDA for anxiolytic properties, which is pretty cool. And basically, the dosing works out to about 1 heaped teaspoon of the dried chamomile flowers, steeped in water for 10 minutes, and drinking that 3 times a day. And that's pretty cool because we know that patients with anxiety don't sleep well. And we also know that patients who don't sleep well become really anxious around sleep. So it's a nice natural remedy that probably your granny's told you to try that actually has been proven in science to potentially be really beneficial, at least on that anxiety level. So briefly, as a take-home message, sleep is important. It is important for us, and we have a role to fight for our patients and ourselves. Just remember, the call system was invented by a general surgeon who was a cocaine addict. So unless you want to take up cocaine, it's not normal to be expected to be awake all the time. Sleep is not a waste of our time. And sleep hygiene is important for everyone. It starts the minute we wake up. And regarding sleeping pills, to really be careful, to really think 3 times before prescribing, to never give them chronically unless you are a sleep physician. And finally, to really just bring it into your conversations with your family, your friends. We need to change the message in our society around sleep. Thank you.
Thank you so much for such an informative presentation, Yakira. I honestly learned a lot from that. And just to sort of highlight an important point that you made is, with this hustle culture that seems to affect our generation a lot, like you said, sleep is for the weak. I'll sleep when I'm dead. And we've really glamorized and romanticized getting less and less sleep, not fully appreciating or understanding both the short and the long-term risks. And especially in the medical profession, it's almost become a competition of who can get the least sleep, if there's an exam tomorrow, I only got 4 hours of sleep. You got 5, you'll be fine. Or on call, you got 2 hours of sleep, I got none. So clearly I'm a harder worker than you are. So I think that's such an important point that you made. If you have any questions, you can pop them in the chats along or just pop up your hand and we'll get to you in a second. I'm just going to start off with 2 quick questions of my own for you, Yakira. So I recently did the long travel from America to South Africa, and I am suffering from jet lag. So what recommendations would you give to someone to overcome jet lag in sort of as natural a way as possible?
So that's a really, really good question, and I think affects everyone at some point in this, if we're fortunate enough to be able to travel. So the whole thing is, it depends if you're going east or west, okay? Because if we're going eastwards, it shifts everything earlier, sun rising earlier, and means we have to go to sleep earlier. And fundamentally, that's actually more difficult for our bodies because our natural circadian rhythm is longer than 24 hours. If we're going westwards, then everything's later, effectively. So it's slightly easier because what you have to do, you just have to keep yourself awake. So there are a few things to look at, right? So the timing of meals is a very important point. So like we said, carbohydrates keep us awake. So when we're going westwards, we want to stay awake later. We want to have that really big pasta for dinner. When we're going eastwards, and now we're sitting in Australia, and we're like, woo, ready to party, and everyone's going to sleep. That's the time for the salad, quite honestly. Okay. Then there are a few other things is light exposure. So getting natural sunlight is very important. It really helps us reset our circadian rhythms and helps to keep that wake state of that circadian rhythm to counteract the sleep pressure that's building up. If we think of that 3rd or 4th slide. So that means that when we travel eastwards, we want to try expose ourselves to that early morning sun to really get our cycle earlier. And when we're going westwards, and then we're sitting in Australia again, We want to be extra mindful to give ourselves less light close to bed. And we didn't talk much about blue lights and lights, etc., but definitely for a bit longer. So if normally you put your phone to that blue light mode an hour before bed, give yourself like 2-3 hours, because you're going to be extra sensitive to the light keeping you awake. The opposite is true when you go westwards, right? You want to stay awake. You're sitting in Miami, you want to enjoy that beach. So you want to expose yourself to as much light as possible, actually, until as late as possible. And then just briefly, melatonin this is where it's been proven successful. And you want to then take it an hour or so before your desired bedtime and give yourself that full 8 hours to really sleep. Because ultimately, what the problem now with jet lag is your melatonin's out of sync. So taking some synthetically is really beneficial in these cases. Just a brief word on melatonin is you get it in different forms. So you get a prescription form called Circadin. I personally prefer that to the over-the-counter supplements at like Discam, because we know what's in it. That's the only reason. Unfortunately, like any other supplement, buying it in Discam means we don't always 100% know what's in it. So melatonin, and you need to go to bed earlier. So salad for dinner and no lights, and hopefully you'll start to feel better soon.
Okay, thank you. I appreciate that. I will go for an early morning walk tomorrow morning when I wake up.
Absolutely.
And yeah, and another question that I think will be applicable to a lot of people here is, when people have done these 24, 30-hour shifts. Now you've been awake the whole night, you get home at 10, 11 in the morning. From what you've read and your experiences, what do you think is the best way to deal with that when you get home? Do you stay awake the whole day and sleep for a longer duration at night? Do you take a quick nap, try stay awake for a few hours and then get a full night's sleep? What would your recommendations be for dealing with those long shifts and coming home?
Okay, Roxy, that's an excellent question. And I think like anything else, there isn't necessarily a one size fits all. So just bear that in mind, that you need to consider yourself and your circumstances. But effectively, how sleep debt works. So sleep debt means you didn't sleep, you're now really, really tired. It is not a 1-for-1. So let's say you got no sleep tonight. You don't necessarily now need to go and sleep 16 hours to make up that energy lost. The body adapts. So we increase our depth of sleep. So our stage 3 and our non-REM sleep becomes even deeper and even longer to catch up for the lack of sleep we had. So personally, I think it's mindful to just what your day looks like. What works well is to kind of go home, give yourself a nap time, but be very mindful. Be very mindful that if you let that nap go on, and I know so many times this happens to people, you sleep for suddenly 8 hours because your sleep pressure is so high. But then what happens? Come nighttime, you can't sleep again. Your sleep pressure is gone, and your circadian rhythm's out of whack because you've now spent the whole day in a dark room. So now you can't sleep at night. Now you're going back to work post call, and you haven't slept again. And that is what you want to prevent happening. So you want to go home, give yourself 2 hours, maybe 3 hours most, to sleep off a little bit of that imminent sleep pressure, and to give yourself a little bit of that breather and let your mental health improve slightly and your emotional regulation, and rather focus on really giving yourself a bit of a good sunlight, having that sleep pressure and having an early night, and give yourself that full 8-9 hours of night to sleep properly and sleep deeply and reset your rhythm, because that's what you need to do. You need to actually prevent this weird set of your rhythm when now you don't sleep at night and you sleep in the day. That only works if you nurses and do shift work. Perfect. I don't know, does that help?
Yeah, absolutely. That's what I found helped me most as well during internship in ComServe. I know we are out of time, so if you want to drop off, then please feel free to. Otherwise, we're just going to quickly run through the last 2 or 3 questions, if that's okay. Would you suggest referral to a sleep specialist after a failed trial of sedatives or pharmacotherapy, or when it is diagnosed in the GP setting? When would you refer someone to a sleep specialist?
So I think, unfortunately, in South Africa, we have very few. There are very few private sleep labs. There are just very few. And I really think at most levels, considering how common insomnia is, it's okay to start by treating patients in your own practice. And again, I wouldn't jump to those sedatives. I would say you start with the sleep hygiene. And if that doesn't work, you really try to bring in stimulus control and sleep restriction. And then you start bringing in the medications and you trial it for a month. You start maybe with your Z drugs, depending on what they're suffering from and their comorbidities, obviously, but you can start with your Z drugs, for example, and give it a month. At that time, really, you want to make sure though that they've set up those good sleep hygiene practices so that you're not having those drugs take over. And then only if that's really not working, then you want to try and help them with cognitive behavioral therapy for insomnia. That's usually is usually done by certain psychologists, and then sleep specialists. The other time to think of sleep specialists is when there's a red flag telling you that this isn't simple insomnia. So patients with other disorders. So maybe you're picking up obstructive sleep apnea symptoms. They stop banging questionnaires like tick, 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 tick. Their wife is like, help me, I can't sleep because my husband snores all the time. So don't forget that snoring, it doesn't just affect the person with OSA, but their partner and their family and everyone around them. So now you have an entire household of crazy sleep deprived people all in one place. That's a disaster. So that's a person who needs referral. And I think, or if you're picking up that the person, something else is wrong, right? But I would definitely say you can, as a GP, feel confident to at least start with the basics. It gets a lot of people right, and it's a good place to start. And you know, only when you start to feel there's a failure of first, second, third line activities, then by all means, of course, then they need a referral.
Yeah, I think we often try to focus on, magic pills and solutions and not just the basics. So the basics will probably sort most people out. How long do the effects of jet lag last? Would we be able to reset our rhythms once we land back home after a trip? That's an interesting question.
Yeah, so it's very person dependent. Some people are very much more sensitive to jet lag than others. I'll give you an example. I mean, even when it comes to sleep hygiene, what everyone's sensitive to is different, blue light filters, things like that. So I know for myself, I'm not, thank God, prone to jet lag. So I can travel and just get on with it and make it happen. My husband is also not, and we were very lucky, but we did a trip with his family and you literally saw these massive effects where half of us were okay and 7 days later, the other half were dying. I think what it really comes down to is, can you reset it? Absolutely. So I hope some of the tips that I gave Roxy is useful for everyone. Using melatonin supplements is a must. And then especially just trying to really be strict with yourself and kind of accepting that maybe today you're going to feel tired. So I know it's terrible and it's such a horrible feeling. It is the same as that post-call though. It's about not giving into the naps, because those naps are completely throwing off any chance you have of realigning your circadian rhythm. So by staying awake and just naturally jumping in, going to sleep at the right time, waking up at the right time for that place, even if that means being tired, you are more likely to reset that circadian rhythm faster, because the things it wants are melatonin, which you can take, and sunlight, and natural lighting, which you can get into.
Perfect. And then just one last question. Nyasha, I see you did ask about the lifestyle medicine certification, so I will email you about that. But just one last question for you, Yakira. What would you suggest for anxious children not sleeping well? Is chamomile tea preferable?
Okay, so I'm so sorry. I'm going to be 100% honest. I didn't come across chamomile tea trials specifically in children. Unfortunately, I can't have come across any trials done specifically in children. So I'm going to start off by saying that. And I think that is sad, because it does maybe prove that we're not addressing the fact that children these days are very anxious and it's a struggle. I think the anxiety there, then chamomile tea should be safe. right? We see no side effects from it or interactions. So it's definitely something. And on top of that, what it can also be is part of that operant conditioning for children, that I'm having this cup of tea, this makes me sleepy, then I go to bed. So it's part of that setting up for their brains a sleep routine. I think it will depend on the child and what the anxiety is about. If the anxiety is a generalized anxiety disorder, which unfortunately we're seeing very commonly in little kids, then it's about really taking that a step further and saying that this sleep difficulty is a symptom of a much greater problem, and we need to address that. So I don't know how old this kid is, but I think what's really coming out of a lot of the mindfulness and positive psychology research is we need to be teaching our young children to sit with emotions. We need to be teaching them to regulate their emotions. It's things that I think our generation is slowly learning more as adults, but we weren't even taught this as kids. So it's really about trying to help them with that anxiety and teaching them, I would go the natural route with a child, because we don't want to medicate our children. We don't want any hangover effects we don't want to disrupt that sleep architecture with all those learning and when all those memories are being consolidated. So I take it a step back, integrate chamomile tea, teach them meditations and breathing exercises, and see if that helps. And I think if none of that's helping, then to definitely consider your pediatrician and a child psychologist or play therapist, really, to deal with the overarching anxiety theme and how they can manage it throughout their day.
Perfect. Well, thank you for answering all of those questions, and thank you for an incredible presentation. Again, it was so great to hear from you. And thanks to everyone for joining us tonight, and hope that the load shedding schedule treats you kindly, and enjoy the rest of your week. Thanks for joining us.
Thank you so much. Have a good evening and sleep well. Bye.
Bye, everyone.